Welcome to everyone. We're going to get started in a minute. Hope everyone's having a great afternoon.
Hello.
We're going to get started in just a moment.
Sounds good.
All right. Good afternoon, everyone. Hope, again, everyone's having a great Thursday afternoon. My name is Joel Johnson, and I have the pleasure of serving as the President and CEO of TASK, Treatment Alternatives for Safe Communities. But more importantly, I have the honor of facilitating today's webinar, Approaches to Housing People Living with Substance Use Disorders, Harm Reduction and Implications for Justice-Involved Residents. As a part of JCOIN and NIDA's support of JCOIN, we've been looking at a number of opportunities to address evidence-based practices in treatment and looking at the interface between the justice-involved population and social determinants of health have become a real big focus for some of the things that we've looked at. And so this webinar today helps us look at an aspect of social determinants of health. But before we get started, I'd like to introduce our colleague from NIDA who will bring greetings, and then we'll jump into the meat of the agenda today. So Dr. Laurie Ducharme. Dr. Ducharme has been a program officer at NIH since 2008, having worked at both NIDA and the National Institute on Alcohol Abuse and Alcoholism. She oversees a portfolio of research, small business, and training grants that explore ways to increase the adoption of sustained use of evidence-based practices, enhance integration of addiction treatment in general medical settings, improve service access and utilization, and build organizational linkages between the criminal justice and public health systems. While at NIAAA, she led the development of the Institute's Alcohol Treatment Navigator, an online resource for offering a strategy to help individuals find evidence-based alcohol treatment services. Prior to joining NIH, she worked in both academic and contract research settings, studying the evolution of the US addiction treatment system in response to changes in financing, regulation, and the introduction of novel medications and behavioral health therapies. Dr. Ducharme received her PhD in sociology from the University of Georgia. Laurie, welcome.
Joel, thank you very much. And just on behalf of NIDA, I want to say thank you to the whole team today. So that includes TASK and APF and the JCOIN Coordination and Translation Center and our speakers for developing today's webinar on a really critical, but I think often underappreciated topic. And so as those of you who are joining us today have probably heard us say before, the vision that guides all of our activities within JCOIN is that every individual who has a substance use disorder and comes into contact with the criminal legal system should have access to effective substance use treatment, both while they are detained and when they are in the community. But the point of reentry is fraught with a host of challenges for individuals to establish themselves in a safe and stable and supportive environment that is absolutely essential to promoting recovery and reintegration into the community. And the very most basic of those needs is housing security, which itself is a key social determinant of health. At NIDA, we are acutely aware that we cannot solve the overdose crisis by focusing only on overdose or substance use or treatment. It really requires sort of a whole person, whole community perspective to ensure that the full array of services are being provided to meet all of the needs of people with substance use disorders to give them the best opportunity for success. What you'll hear in today's webinar is research that helps describe just how critical housing is to promote both recovery and reentry into the community. You'll hear about some of the different models or approaches to housing services that are available for individuals with substance use disorders. and some of the practical challenges of providing these services, particularly for people with criminal legal system involvement. So thank you, all of you, for being here this afternoon. I really hope you find this webinar to be informative and useful for your work. And with that, I'm going to turn it back over to Joel to introduce our speakers.
Thank you so much. Appreciate it. So we're going to start, and this is a really great panel. I hope you all find it as interesting as I have just preparing for this today. So our first panelist is Dr. Carrie Pettis. Dr. Pettis is one of social work's leading experts on enacting data-driven solutions to criminal justice reforms. Her intervention, development, and policy reform work facilitates racial and economic equity throughout the criminal justice system, from an individual's first contact with law enforcement to their release from incarceration. She concentrates her direct practice intervention research on working with community partners to develop and research behavioral health interventions to enhance positive social supports, respond to lifetime trauma experiences among justice-involved adults, treat substance use and mental health disorders, and generate overall well-being for those impacted by justice involvement. Dr. Pettis' work has broad policy impact, and her prioritization of the rapid dissemination of research findings to policymakers, practitioners, and advocates ensures that data-driven innovation can be implemented in real time. Dr. Pettis has grounded her career in intervention development and testing based on strong collaborations with correctional stakeholders, community partners, and individuals with incarceration histories, maximizing both the relevance of intervention content and the potential of effective interventions to be implemented in real world settings. Prior to joining the Justice Systems Partners, Dr. Pettis founded and led the Institute for Justice Research and Development, a premier multidisciplinary research center located in the College of Social Work at Florida State University, Yay, Tallahassee. Before joining academia, she worked extensively as a social worker in varied mental health and correction settings. Dr. Pettis completed her doctorate of social work from the University of North Carolina at Chapel Hill. She holds a Master of Social Work Administration degree and a bachelor's degree in social work and psychology, all from the University of Kansas. Dr. Pettis, welcome.
Thank you so much for that introduction, and I'm excited to be here today. I'm going to share my screen and here we go. Make sure that this is coming across. Yes, I have now become a floating head for you. So my role today on this panel is to really just give kind of some background information about what housing stability looks like for individuals after incarceration, and to present a very recent study on housing stability and reentry in the current era, including times of COVID. So in general, what we know, oops, this is switching on my wrong screen. Okay. In general, what we know from the research is that about 1/3 of individuals who return home from prison have housing instability, and about 10% are houseless at some point during their first year post-incarceration. And when we think about the fact that approximately 600,000 people are released from prison incarceration each year, that's a large amount of people that are experiencing housing instability. And these statistics are really consistently identified across studies. What studies across various samples have also identified is that if an individual becomes houseless during the reentry period, which is approximately that first year after release from incarceration, they're at increased risk for coming into contact with law enforcement, being arrested for sleeping in public spaces, and other types of infractions that are considered illegal that can result in somebody becoming reincarcerated as well. We also know about the increased risk for various behavioral health symptoms once related to housing instability during the reentry period. The majority of what we know right now about housing stability for individuals during reentry focuses really on homelessness or houselessness after incarceration. And there's some attention to what changes in housing situations look for people throughout the reentry period. So we wanted to, in this study, to really understand not only to the extent is houselessness and homelessness occurring, but what other types of housing instability might be at play that is influencing people's incarceration after an incarceration, influencing people's outcomes after an incarceration experience. So this study that we did was one of a series of reports of a large multi-state randomized control trial that was looking at the impact of a well-being based behavioral health intervention called the 5 Key Model for Reentry. That larger study took place across 7 states, across multiple years that we divided into phases of the study. The sample that I'm going to be presenting on their housing instability experiences after incarceration today, sorry, I forgot to advance the slide. The sample that I'm going to be presenting on was 420 individuals in the control group or the comparison group of the study who were released from one of 36 prisons across Indiana, Ohio, and South Carolina. And this sample were interviewed post-incarceration directly by research team members, and they were asked about a range of biopsychosocial factors, including their housing stability at two weeks post-release, 8 months post-release, and 14 months after release. As it related to housing stability, we asked them who they lived with, if they considered themselves homeless, whether they pay rent or mortgage, and how often they know where they're expected to stay. So approximately, 2 weeks after their release from prison, nearly 60% of individuals reported that they were living with some type of adult family or friends. Under 30% were living alone or with a spouse or a romantic partner, and approximately 1/3 of the individuals said they were also living with children who were under the age of 18. When we asked people where they lived, we saw that about 60% were living in someone else's home, and about 1 in 5 were in their own home. Another 10% indicated that they were in highly unstable living situations, living in a hotel or a motel, in a transitional housing program, or on the streets or in their car. And 13% were living in a halfway house, work release center, or some type of correctional setting where they weren't fully back integrated into housing by them, and in housing by themselves. As of 14 months, if we fast forward to 14 months later, we found that people were about 40% of people were in their own home. Fewer than half of them were still in somebody else's home. But at 2 weeks, we had 10% of people who were in highly unstable living conditions. And we fast forward to 14 months later, and we're still seeing around 8 to 10%. We're still in these highly unstable living arrangements. And we really saw between houselessness and just housing instability across the 2 weeks, 8 months, 14 months time periods during the reentry, where about 18 to 24% of individuals are in highly unstable conditions. At the 14-month time period, we saw a little bit of an increase in people living alone or living with a partner, but we still saw the majority of people were highly dependent on, or at least highly likely to still be living with some other individuals. And when we asked people some more targeted questions around whether they considered themselves homeless or not, or how sure they were or unsure they were of where they were sleeping at any given point, we see that, again, the highest amount of reported perceptions of experiences of homelessness are in that 2 weeks post-release, but it doesn't change or go down that much over the subsequent 8 months and 14 months after release. In terms of people being unsure of where they're sleeping most nights, even if they are staying with friends or family or in some other type of transitional setting, we're still having a large percentage of people report that they don't exactly know where they're staying. This stays fairly consistent throughout the course of the reentry period. Again, suggesting that housing instability is a fairly chronic situation for a good proportion of people after they release from incarceration. We do see on the other side of that some people are paying rent or paying mortgage and are identifying ways to have some type of housing stability. And that suggests that there are ways to overcome the barriers and ways that interventions can seek to support these outcomes for more people. And we're going to be hearing about some of those programs and approaches today. And I would say that, the key takeaways from this study and some of the literature that we've looked at too, is that there does seem to be this a subsample of people getting out of incarceration that are struggling with housing and housing stability immediately upon release, and that continues for that subgroup of people well into their post-release period. We also see through this study and through these data that living with other loved ones and friends and families is a way in which many people achieve housing stability. And that suggests, as we're having these conversations and exploring solutions around maintaining housing stability for all after incarceration, that we really look at ways in which families or loved ones may be incorporated into our policy and practice innovations along the way. Now, Braden, I believe we're holding questions to the end, but I didn't know. Joel, okay, I'm looking at Joel nodding. All right, so that is all I have to say for right now, and I will turn it back over to Joel.
Thank you, Carrie. Appreciate you. Yeah, a little housekeeping. We will hear the presentations from all of our speakers, and then we will move to questions at the end, just to make sure we receive all of the content. In the meantime, if you do have questions, please use the Q&A function on Zoom in order to ask your questions, make it easier for us to get to them as we move along. So thank you again. Our next panelist is Dr. Dennis Watson. Dr. Watson is a senior research scientist at Chestnut Health System's Lighthouse Institute in their Chicago office, and affiliated faculty in the Center for Dissemination and Implementation Science at the University of Illinois School of Medicine in Chicago. His research primarily focuses on the development, implementation, and evaluation of behavioral health interventions. Various federal, state, and local funders, including the National Institute on Drug Abuse, Centers for Disease Control and Prevention, Arnold Ventures, and the Fairbanks Foundation, have supported his research. A considerable body of his work is focused on harm reduction, recovery supports, and treatment linkage interventions for people who use illicit substances or who have a substance use disorder. His prior research focused on the housing first model of permanent supportive housing, has helped guide his housing services implementation in the United States and abroad. His most recent work investigates effectiveness of peer support and treatment linkage services delivered through both in-person and virtual modalities in emergency medicine and community-based settings. Dr. Watson received his master's and doctorate degrees in sociology from Loyola University in Chicago in 2011. He also completed a master's degree in clinical research from Indiana University as a part of his postdoctoral training. Before joining Chestnut, Dr. Watson was a tenured faculty member at both Indiana University, Purdue University in Indianapolis, IUPUI, and the University of Illinois at Chicago. Dr. Watson.
Try to get my screen shared here. 1 second. And okay, is everybody seeing that? Okay, good. So first off, I just want to thank NIDA and TASC for reaching out and inviting me to be a part of this panel. Today, I'm going to be talking a little bit about broadly some background related to homelessness, but specifically chronic homelessness, as well as talking at the end of the presentation about some of my research. That research was funded by NIDA through 2 separate grants, just to get that up in front. And then also I want to just acknowledge some partners that have been with me pretty much along the way with a lot of this work, which would be Heartland Alliance's Midwest Harm Reduction Institute, from which we will hear from Ed Stellon after I speak, and then also the Corporation for Supportive Housing and the AIDS Foundation of Chicago. So I just want to give a little bit of background to start off with on homelessness in the United States for folks who might not be as familiar. I'm using 2020 figures because the 2021 figures nationally actually were a bit of an undercount. The homeless count is always kind of an undercount because by the nature of being homeless, people aren't always easy to be found, often for safety reasons. They don't want to be seen sleeping unsheltered on the streets. And so the 2020 figures are probably a better count than 2021, which actually did not go out on the streets and look for people because of the pandemic. So in 2020, they did both count people in shelters and on the streets, and they counted, just over 400,000 people in the United States experiencing homelessness. 27% of those folks had what would be the federal designation of chronic homelessness, and that just means that they have some sort of diagnosed disability that can be a physical disability, a mental health disorder, or a substance use disorder. And they also have been homeless continuously for 1 year. And if they have not been homeless continuously for 1 year, they can still be designated chronic homeless if they have had 4 episodes of homelessness in the past 3 years. This is different than the majority of the homeless population, which could be considered to be transitional or temporary. And these individuals tend to not suffer from as many complex issues, not having a disability, not being homeless for as long of a time. Oftentimes, people that fall into this transitional or temporary category are experiencing financial difficulties that, if the resources are really in place, can be taken care of and they can be rehoused really quickly and stably. But when we are going back to look at the chronic homeless designation, even though they are only about a quarter of the population, they do consume a large amount of the resources, not just from the homeless system, but also from emergency medical services and from the criminal justice system, just by the nature of their complex needs. So, and, I think this already was pretty clear with Dr. Pettis's presentation. There is overlap, obviously, between homelessness, substance use, and incarceration history for individuals. We know that formerly incarcerated individuals are more likely to have substance use issues than the general population and to become homeless than the general population. A large portion of people who are experiencing homelessness have histories of criminal legal system involvement. individuals in shelters tend to have significant histories of arrest, and people who are homeless are at higher risk of being arrested. Also, persons experiencing homelessness in terms of substance abuse outcomes are at greater risk for suffering harms. A recent study that found that individuals across 4 states who were in shelters, who were homeless compared to low-income individuals who were housed, actually had higher risk of hospitalization for overdose and hospitalization for other opioid-related reasons, just as one example. One thing that I think is important to understand about this population and these complex issues is that they can often create what I like to think of as revolving doors of homelessness cycles. And so if someone's incarcerated, we know that it can be more difficult for them to obtain housing because of discrimination in the housing market. Private landlords aren't as likely to accept applications for people. When you are experiencing homelessness, as was previously said, you can be more at risk for being arrested because you might commit a crime for survival needs. You might need food. You might engage in sex work to obtain resources or safety or protection. You might be picked up for nuisance crimes like loitering, or you might also just be more likely, just from the fact that you do use drugs, you're more likely to use them in the open and can be seen and arrested for that. Also, there, if we look at this left, the circle on the left here, there's also can be a cycle of homelessness related to housing structures. So if someone is homeless, they obtain housing and they engage in substance use, or they have a substance use disorder and they relapse while in that housing, that puts them at risk of eviction, which can then put them back living on the streets, which then again puts them at risk for engaging in the criminal justice system again. And what we also know is that, housing can be the solution to this cycle, but not just to ending this cycle, not just housing, but housing that is stable, that provides the right supports to make sure that people are not getting evicted and put back out on the streets and being put at risk for incarceration again. So in the United States, traditionally, the way that we have housed people since the 80s has been known as the treatment first or continuum of care approach. This approach starts with someone on the street gaining access to the shelter system. And while they're in the shelter system, they typically would have to go through a lot of hoops in terms of obtaining sobriety, potentially having to get a job, being involved in mental health treatment before they're allowed to move to a temporary housing accommodation. Once they're in temporary housing, they still have to meet a lot of those same requirements before moving into a permanent housing situation, which again, often would have similar requirements. And if someone was not meeting those requirements, they could be at risk for eviction. This way of housing people tends to work okay for the majority of the homeless population who are experiencing temporary homeless more due to financial difficulties, but it can be difficult for individuals who are experiencing chronic homelessness, who have substance use and mental health issues. So in the late 90s is where this is typically attributed to the housing first approach. The housing first approach, though, has existed before this in different iterations, probably since at least the 70s, but it was really in the 1990s with the Pathways to Housing program and research that was done there that got it established as an evidence-based approach. The housing first model as an alternative recognized issues with housing people who are experiencing chronic homelessness and decided that we're just going to get rid of all of these steps and we're going to put people in housing because housing is really what they need. So from this approach, we see housing as a human right. It prioritizes tenant choice to any degree possible. They have a low threshold admission requirement, meaning that if you are using substances, you're still eligible to get into housing. Really, the only thing that bars you from getting into housing would be that you are a threat physically to someone else or to yourself. Also, there are minimal service requirements once people get inside the housing. However, just because there aren't service requirements does not mean that we should not have assertive supports for people. We should be engaging them. We should be making services available to them and let them know those services are available. And what is really key is this harm reduction approach to services, which just simply means working with individuals in a way that helps to reduce the risks associated with their substance use if they are choosing to engage in that substance use. So it's really that low threshold admissions requirement that gets people in the door. But unless you're practicing harm reduction, you're really putting people at risk of subsequent eviction. You're also putting them in housing with a very low threshold, and then you're raising the bar for what it means to stay there. So that harm reduction component I want to get across in the rest of the presentation is really important. And this is really how I like to think of housing first. It's, going back to psychology 101 for a lot of people, Maslow's hierarchy. You really can't begin to focus on the things that we need for recovery, like self-actualization, self-esteem, self-efficacy, until we address basic physiological safety through things like housing and relationship building with others. And that's another thing about the housing first model, is that because people aren't feeling judged, they're not feeling like they're at threat of eviction, it's easier for staff to form trusting, longstanding relationships with them. And that's key to making sure that individuals will inform them when they are having problems before they get out of hand, so that they can then develop strategies to make sure that individuals are not putting themselves at risk of eviction. Housing First works. It's recognized as a preferred practice by the federal government, multiple institutions in the federal government. There have been 4 solid randomized controlled trials to date, a ton of quasi-experimental studies and observational studies. We know that Housing First leads to greater housing stability. The tenants in housing programs that are Housing First compared to treatment first programs perceive that they have greater choice in their lives, a better quality of life. There are reductions in symptoms of mental illness and improvements in mental health outcomes compared to treatment first housing as an alternative. Also reduced recidivism and criminal justice contacts. I think that this is really key, is that once people are housed, they're not out on the streets at risk of being arrested at such a high degree. Also, I think it's important to put out there have been mixed findings regarding substance use disorder symptoms when we're looking at treatment first versus housing first. But this is likely because we're not measuring the right things. Oftentimes, I mean, it makes sense that a program requiring abstinence is going to have more individuals in it who are abstinent or using at a lower rate. We should really be looking at alternatives related to the risks associated with substance use as an outcome. Or I think, it always goes back to greater housing stability should be the main outcome of Housing First, because the goal is to get people housed and keep them housed. So switching to talk a little bit more, or more focused on my research, what I have been interested in is the implementation of the Housing First model. And I've been very interested in this concept of model drift. So we know that there have been these studies that have demonstrated Housing First works. They do Housing First in a certain way, but when it gets out into the community, that's not always what we see as being implemented. And if that's not implemented correctly, then people are going around saying they're having difficulties with the Housing First model, but it's really not the Housing First model that they're having difficulties with, because they're not actually practicing it. So there's mainly 3 things that I see that have contributed to this model drift. The first one is that when the Housing First model first became popular back in the early 2000s, it was talked about a lot, but there really wasn't a lot of fine-tooth description about what it entails. And I think that the biggest thing that got left out of it was the harm reduction component. I mean, everything you read said we let people in the door with minimal requirements, but it didn't say we practice harm reduction with them. And that probably had to do with the fact that back then it wasn't as easy to talk about harm reduction. And so I think it kind of got buried in the discussion as the model was being advocated. Also, since probably about 2011-ish, we've seen that there's been this move from to a Housing First system across the US. The model has been picked up, it's become more ubiquitous. But what that means is that we're focusing on a system that identifies people in most need on the street and places them in any housing program that can meet their needs, regardless of whether that housing program is practicing Housing First itself. So this takes away from the fact that there is a program level Housing First fidelity that if someone is saying that they're a Housing First program needs to be met. I've actually talked to people who are part of Housing First systems who believe that every program in their system is Housing First because they identify people who are in the most need and place them. And that's just not the case. Also, there's just been weak funding requirements related to if someone does receive funding because they're a Housing First program, they're not really asked to demonstrate how they are meeting those expectations that should go along with that. And so the work that I started off with back in about 2009 was really inspired by a lot of the work I was doing with Heartland Alliance at the time. And what we had identified was that there were these sort of issues happening in Chicago where people were practicing Housing First, but they weren't really doing the harm reduction. And so we realized that there, at the time, there wasn't a fidelity instrument. Unbeknownst to us, Pathways to Housing, which I mentioned earlier, was creating an instrument at the time, but we didn't know that, and we decided to create one. So we created an instrument by first looking at 4 programs in Chicago that were doing a really excellent job of Housing First based on expert opinion, trying to figure out what their sort of secret sauce was to what they were doing, then developing an instrument that we ran by some experts nationally. And then we actually went out and tested that instrument. It was a phone fidelity instrument, an instrument that could be administered over the phone. We administered it to 51 programs. And what we found was sort of this nationwide evidence supporting this whole idea of model drift. We had 12 programs that identified as abstinence. They said they were abstinence-based, treatment first, and lo and behold, our instrument did demonstrate that. We had these programs that said they were Housing First, that were really doing harm reduction and Housing First practices. And then we had 18 programs that told us that they were Housing First, but they were really doing more treatment first practices around requiring abstinence and sobriety and requiring a lot of service participation from their clients. When we actually looked at the scores on these instruments, we found that the instrument was sensitive enough to predict, or to identify these programs and separate them from each other. But what we also found was that those programs that said they were Housing First, that actually were doing the practices, had the best housing retention overall. And I think the key to this, this whole idea of harm reduction, in my opinion, is, and what I've seen on the ground, is really that a lot of places, it comes in 2 flavors. One is they say they're Housing First and they're not really doing any harm reduction. They're requiring abstinence. They have a lot of hoops that the clients have to jump through to get housed and stay housed. However, there's also this other flavor that is, we do use harm reduction, but our harm reduction is we just don't sort of bring up substance use with our clients. We don't talk about it. And in some ways that can be even more problematic than requiring abstinence, because tenants don't really know what's expected of them. They're constantly wondering what's going on, if they're going to get in trouble for substance use. They don't really understand that they're in a program that practices harm reduction. And it also means that they're not talking to the staff. They're not telling them about their substance use in a way that those staff can then intervene, develop strategies, and assist them when they might need assistance. And so after we completed the study with the fidelity instrument, partnering again with Heartland, we developed a implementation strategy combined mainly of two strategies: a training component that was composed of 4 e-learning modules that we'd asked organizations to take 1 month to go through. They could go through them at their own pace, but we asked them to have all staff complete them. And then we also had 6 months of consulting that we did after they completed the trainings. And so it was a total of 7 months. What was we really tried to focus on in this strategy was we didn't want to give people facts, because what we'd seen through doing trainings in person was that when we gave people numbers and facts and told them about studies, if they weren't bought into the harm reduction component of the model, it did not help. And it actually kind of further entrenched them in thinking that abstinence was the better approach. What we did was we focused on telling stories and telling stories in the voices of, we actually used recordings of people talking, but in the voices of people talking about their experience with the model, both clients and service providers. We also focused on having them talk about, points where they didn't believe in harm reduction, but then as they started to use it and see its successes, how it could improve things. And we really tried to make sure that those stories were realistic. We didn't want to give stories that at the end everything was tied up with a neat bow. We really wanted to show how, there was progress, but that progress might not be exactly what we always expect, but it was still better. And what we ended up seeing from this at the end of the study, we did this strategy with 3 programs that were in different states, all 3 in the Midwest. And we used one program that was brand new that had never done any housing treatment first or apps or housing first, one program that was switching from a treatment first model to a housing first model, and one program that had been practicing housing first but wanted to improve. And what we saw was that at the end of our e-learning trainings, there was really high satisfaction with the training itself. We saw improved attitudes towards harm reduction among those who actually did not have as high of attitudes at the beginning, which was exactly what we were aiming for. We saw that they had improved knowledge, testing them from baseline to the end of trainings. And then we also saw that the programs had improved fidelity over time. So on this figure, T1 is baseline before we started doing anything. And then T2 and T3 were through the course of the strategy, and then T4 was after the strategy ended. And we did see consistent improvement from T1 to T4. That little dip from time 3 to time 4 for the organization 2, that actually, we still are trying to figure out what went on there, but we think what happened was this actually should have been more of a flat progression, because there was a problem with the way that our trainers might have rated the data at that time point. But regardless, we do see an improvement across all the agencies from baseline through to the end of the strategy. What we found was, what I think is really important, is that oftentimes organizations think training is the answer. It is not always the answer. Training was really a foundation. And even though all the organizations liked it, they all said that the consultation was really what they needed to help them learn how to take what they got out of the training and put it into practice. And that's because harm reduction is not a black and white strategy. There's a lot of gray, there's a lot of complexities, and it takes people a while to get comfortable with it. And they have to have what they do be reinforced by someone who is an expert. Also, they thought that the narrative stories that we put in were really helpful to them, because they felt that they really reflected their actual experiences as providers compared to other trainings they had been in the past, and that helped them to get in and to understand harm reduction and the housing first model better. So just to conclude, I think the main takeaways for me from doing this work is that housing is really a solution to ending a lot of the cycle we see of people revolving in and out of the street. Housing first works, but it's really often there are problems with implementation and practice, and harm reduction is often that key element that is overlooked or not implemented well. But we do know that appropriate supports can overcome the barriers to its implementation. If anyone's interested in the modules, they can contact me and we can talk about it. But otherwise, thank you very much.
Thank you, Dr. Watson. A lot of information there. Please put your questions in the Q&A and we will answer them. Some we've answered in real time, but we'll revisit them for everyone's benefit and make sure that we get answers to your questions. Our final presenter today is one of my partners in service, Ed Stellon. Ed Stellon serves as the executive director for Heartland Alliance Health, where he oversees the organization's integrated primary care, oral health, food and nutrition, and behavioral health services for individuals and families who are experiencing homelessness or living with HIV. Heartland Alliance Health aims to improve health outcomes for Chicago's most vulnerable populations by addressing the social determinants of health along with healthcare itself. During his 30 years at Heartland Alliance, Ed has worked to braid funding from substance use, mental health, housing, and primary care solutions to build an integrated service model that centers on helping vulnerable people achieve optimal outcomes. He is committed to innovative service, service models that promote human rights, and is a founding member of the Midwest Harm Reduction Institute. Mr. Ed Stellon.
Thank you, Joel. And thank you, Carrie and Dennis. Wow, those were really great presentations and your research is phenomenal. What I'm going to do today is I've been working with Heartland Alliance Health for 30 years. Actually, next week it'll be 31. And I started out as street and shelter outreach worker and came kind of backed into harm reduction very early in my time there in the early 1990s, really working with people, especially injection drug users at a time when HIV infection rates were very high and the consequences were terrible. And so what I'm going to try to do is squash 30 years of experience into about 15 minutes. And I am honored to have one of our program participants, Susan Oktoboski, who has joined us, and she's also on with us. And so I want to make sure that we've got, at least 5 to 7 minutes or so to have Susan chime in too. All right, so just to let folks know, Heartland Alliance Health, we've been around since the mid-1980s. We were one of the first 9 healthcare for the homeless programs in the United States. So there was, in the mid-1980s, there was a rise in homelessness. Well, it was sort of a new thing at the time. And by 1985, some big national foundations got together and they funded 9 demonstration projects, and we were one of the first. Now there are healthcare for the homeless programs in counties across the United States. We're part of a larger organization, Heartland Alliance. And Heartland Alliance is a global organization that focuses on human needs, human rights, and really promoting policies that help lower income people, oppressed people from around the globe live the lives that they want to live and can live. And so Heartland Alliance Health is one of the different companies, not-for-profit companies within this umbrella. So HAH, we're the only federally qualified health center in Chicago that is solely dedicated to providing services for people experiencing homelessness. Now, there are dozens of amazing FQHCs in Chicago, many of which are delivering great services, great healthcare, mental health care, other services to people experiencing homelessness. But we are organized around this population. So as a result, our services, they're very relational. Most of the people we engage through street and shelter-based outreach. We deliver healthcare in about over 60 shelters right now in Chicago. We have a van that goes out with the city of Chicago and delivers healthcare in encampments across the city. And then, of course, we have health centers too around the city. But what we know at HAH that it's the social determinants of health that really determine how our folks do in healthcare and what their outcomes are. We know that housing is healthcare. We know that food is medicine. And so we work really hard to address the social determinants of health. Along the way, because we're working with a population of people experiencing homelessness, we also know that there are really high rates of substance use and mental illness. So at HAH, if you're a staff member at HAH, you're more likely to be a mental health worker than a medical staff member. So we really try to meet people where they are. So being mindful of time, I'm just going to kind of keep pressing forward and talk a little bit about our housing. What I'm going to try to do at a high level is talk a little bit about what our housing looks like, really high level, how we fund it, and then go much deeper into how we deliver services. And I really want to illuminate some of the points that Dennis brought up around the harm reduction model. I want to start out by saying harm reduction is absolutely not don't ask, don't tell. It's absolutely not anything goes. Harm reduction is actually, in a lot of ways, it requires us to work even harder and be even more focused in our effort. It is a relationship-driven model. We have to earn the trust of the people we are serving. We have to believe in them in order for them to believe in us. And when they believe in us, they're much more willing to engage and bring us into all aspects of their life. And harm reduction is really that, engaging people in all aspects of their life and helping them weigh choices and make choices all day long. So what does our supportive housing look like? We have both scattered site programs, and then we also have some project-based programs. So scattered site programs, basically we match a person with a housing subsidy or voucher, and then we go with them out throughout the Chicago community. We know some landlords who tend to be good to our participants and good to work with, but regardless of that, wherever the participant wants to live, we call our folks participants because we believe they're partners and they're really, they are the drivers of their care. We're the partners on their journey. And so we go with our participants out into the community to find the right housing spot for them. We do not, it doesn't matter what neighborhood. For us, the community of choice is that chosen by the participant. We also have some project-based programs, and those are programs where people have their own leases, they have their own apartments, but those apartments are clustered in a single building, either on single floors or in one case scattered throughout a large building. We have on-site staff at all times. So just to put it in perspective, we have about 142 units of, we have exactly 142 units of scattered site housing and almost 100 units of project-based. I'm not going to go into details on these next couple slides, but my point here, I think, is to show you the complexity in funding supportive housing. One of the things Dennis pointed out is that housing is not just, housing is the solution to homelessness, but housing alone is insufficient to help some folks who are very, very vulnerable be successful in remaining housed. And in order to help our folks be successful, we not only have to find subsidies or funding for the housing, but we also have to find ways to fund the services. And we draw on a variety of different funders for that, including partners at the state of Illinois in the Department of Human Services and Mental Health, and the Division of Human Service, Department of Human Services and the Division of Mental Health within that department. We also bill Medicaid for some of our services too. And as you go through, you can see we work to braid funding from a variety of different systems to really wrap around our participant population. Behind the scenes, we sort of learn to speak HOPWA, we speak HUD, we speak Medicaid in its different iterations. And then we also work with local bodies too, including the City of Chicago and the County of Cook. All of the people that we're serving, the vast majority of our housing is in the City of Chicago. We have a little bit in suburban Cook. All the people we're serving have experienced some issues related to behavioral health conditions. It could be substance use, could be a mental health issue, could be both. And again, it's a harm reduction model. So it's come as you are. It does not matter if the individual is interested in engaging in treatment for their substance use disorder or even their mental illness. All that matters is that they're willing to partner with us and engage in a conversation about their housing. From there, we really work very closely with people on a day-by-day basis to help people be aware of their options, weigh those options, and make the best choice that they can today. within the context of this particular conversation today, not everyone living in our housing portfolio has a criminal legal system history, but many do, because of at the intersection of homelessness, behavioral health conditions, it often are encounters with law enforcement that draw people into the criminal legal system. I have to say, and I just vetted this fact with the leaders of our permanent supportive housing the other day. We have been providing permanent supportive housing since 1994 at HAH. We have had participants who have found themselves in county jail while living in our residence, our programs, usually for very minor infractions, often called nuisance crimes. But we have not had an individual who has gone to prison, in Illinois Department of Corrections, for a crime committed while living in our housing. There have been a few people who were, in the court system prior to moving in, and the outcome was not good for them, and they did go to IDOC. All of those people that we know actually came back to us, and we found a way to get them housed post-incarceration. But I think that that's an important point, that while living in permanent supportive housing, I think this, Dr. Pettis, this kind of gets to your point about stability, the stability of housing and that impact it has on people's lives. Just going to keep focusing on the time too. So we help people with an array of different, basically whatever the individual needs to stay successful today in the community, stable, housed, and living their best life. That's what we're focused on. So our staff do a wide array of activities. And so here's kind of a list right here. I do want to emphasize that, especially with our project-based programs, it's not only staff who are delivering service. Our participants are connecting one-on-one with one another. And there's a lot of support between our program participants. This is especially noticeable in the last 12 to 15 years. We've seen a rise is we all have across the country in injection drug uses, and opioid use in general. And we know that we've had staff a few times be successful in reversing an overdose, but our participants have reversed many more, exponentially more overdoses than our staff have, not just with their peers in residential programs, but also their peers across Chicago in the streets. And I think it speaks to how powerful and important our participants are, and they are drivers of their success. So most of our referrals actually come to us from every city has what's called a coordinated entry system. This is a requirement that the Housing and Urban Development Department has set forth. And so the vast majority of our referrals do come from the coordinated entry system. We're proud of the fact that our outreach team is responsible for about a little more than a third of the names on our coordinated entry system in Chicago have come by way of our outreach team, engaging people in streets and shelters and getting their name on the list and keeping their name fresh on the list so that they can rise. In Chicago, the coordinated entry system does have a vulnerability index, and among the questions that help determine how vulnerable a person is, the more vulnerable, the quicker you move up through that list. Among the questions is a person's criminal legal background, with a positive being indication of more vulnerability. So again, I think I've really touched a lot on this. One of the services we do provide for our participants. Some of our participants are on some form of disability, and we will provide representative payee services for them, which really helps them manage their funds. And again, it's from a harm reduction perspective. We're not telling people what to do with their money, but we're, like Dennis said, we're rolling up our sleeves and getting into the kind of the muck of the day-to-day life and talking to people about, so what do you want to do with this money? Where are you going to go, and who are you going to be with, and all that, to help people make the best decisions they can. Our philosophy of care is really important to us. I won't say much more about harm reduction because I think Dennis did such a great job describing it, but really I do, if I infuse anything into it, to me, we talk a lot about the strategies of harm reduction, like safer injection strategies and overdose prevention. But for me, really, it's the relationship at the core, the person-centeredness of harm reduction. That's the ethos of harm reduction. I want to see the world through your eyes as best as I can. And in order to do that, I have to earn that. I have to earn your trust. And so to me, that's the core of harm reduction. But we're also believe in trauma-informed services. So recognizing that the majority of the people we work with have experienced some trauma in their life that has probably shaped the way they understand themselves and the world around them, and especially the relationships they have with other people who are helpers. And a strengths-based approach is that we really avoid pathologizing our folks. We avoid looking at diagnoses and problems. Instead, we really try to embrace their strengths, embrace their skills, their resilience, because it's leveraging those strengths and that resilience that's going to really help people move forward. Finally, human rights is at our core. It's the DNA of being a worker at Heartland Alliance, writ large. So I want to ask Susan if you're still with us. I know you were.
I am.
Oh, you are. Okay, good. It's hard for me to see with my screen.
Yeah, the light, you can't see me. Sorry,
I
guys.
see you. Susan, thank you. First of all, thank you so much. I'm so honored that you were willing to join me. And I just kind of have an open-ended question. I'd love to hear a little, if you wouldn't mind sharing a little bit about what brought you to housing and how housing helps you in your journey.
Well, in January, I will be a participant in this program for 7 years. But to start out, I was homeless. And I was grateful to get this one caseworker at a homeless shelter that filled out the CES like you explained. And then I got a call, and it's been amazing, because like 2 weeks into being at Pathways, I lost my dad.
Oh.
So I'm glad I was at Pathways because there was so much support. There's caseworkers that are there. Well, it's different now, but when I was there, it was for the entire day.
Mm-hmm.
And they would do wellness checks. So I felt like somebody cared,
mm-hmm.
And then I stayed sober, and I know that it was harm reduction. So which was great, because if I ever were to relapse, I still would have a place to stay.
Right.
Which gave me there wasn't a fear. And then my caseworker kept trying to get me to do things during my day because I had nothing to do. Mm-hmm. So I kept going and trying things. And then, 6 months into living there, I started taking classes at Truman because it was supportive that I moved to because to become more independent. And that was kind of scary for me because it's like, am I ready to go for more independence? So I was scared, but I've been there like 6 years. So it's, and I feel supported. And, and in 2020, I graduated from college.
Oh, congratulations.
Thank you. And I don't think I could have done it without, Pathways or supportive. you know, and having someone there, just if I'm having a hard day, having someone there just to talk to them for 5 minutes is beneficial for me because somebody heard me, you know.
So there's that social connection with staff and I imagine other participants at times too. And you know, one of the things that you mentioned right away is that you knew it was harm reduction. So you were getting your feet on the ground with a goal of sobriety, but
Yeah.
you also knew, I think, I don't want to put words in your mouth, but the staff had explained harm reduction to you, and you knew that if there were a slip or something went awry, that your housing was not conditional.
Yes.
You could still talk about what went on with the staff.
Yeah, yeah, you know, I did talk to I made friends in Pathways and Supportive, you know, and I had that community base, you know, and I had many times where drugs were like offered to me, which that was hard.
Yeah.
But I said no and walked away. But you know, like, because I don't know, in the beginning, I needed someone to talk to at all times.
Yes.
So I would go to the office, and a lot of the times they'd let me stay there and talk to them for like 20 minutes, you know, and then, you know, and it was great, you know, and, you know, even the caseworkers at Supportive, we have a meeting once a week, and, you know, it's, you know, to stay connected and to know that they're there to help us, you know, and if I ever have a problem with the building, I go to my caseworker or one of the caseworkers there, and they help me, you know, so I'm not alone. I don't have to fight alone.
Right.
You know, because I just, you know, I had an issue with someone at the building, and I told my caseworker, and they helped me fix it, you know, and everything's better, you know. And I just want to point out this one thing. Like I've heard of the bridge program, and I know there's not money for it. So I'm hoping they'll get funding, because that's what I want to do next. The next part of the program, where what I heard was you could pick any apartment in the city of Chicago, and you would help pay just like it is now, subsidized.
Yeah.
And I don't know if that's still, I'm hoping that still is there, just when funding comes, that does happen. Because I wouldn't be able to live in an apartment on my own, because I get Social Security, so I don't make it enough.
Right. And I know we've got people from all over the place on our webinar today, but just so folks know, Chicago is a very expensive place to live. And I know, so first of all, I want to thank you so much, Susan. What we have to do now is step back a little bit, and I think Joel is going to open it up for questions. And Susan, you're our guest of honor, honestly, in my opinion, and you certainly can go on with your day if you want, or if you would like to just hang in there for the next 20 minutes or so.
I will.
If there were questions, you're totally welcome. Okay, great. Thank you. We really appreciate it. Thank you.
All right.
Thank you, Ed, and thank you, Susan. Appreciate you sharing with us your experience. This has been great. And Ed, again, thanks. We have several questions, but let me start asking a couple that came to mind while we were talking. And this is really back to the housing first model. Is there a TA center? If there are people who are participating in the webinar, and there are a few questions about housing first, and if it works, why isn't it done more, et cetera, et cetera. How does someone start a housing first program with Fidelity? Where should they begin? And is there a TA center available to them to help get started?
Yeah, I'll jump in and say, so I said at the end that, people can contact me if they're interested in the modules, but that's just the training component. And I really do believe that it takes consultation if you are not familiar with harm reduction, or your staff are not familiar, or you don't have an expert in-house. The modules that we have are available. I believe they're still available. I have reached out and tried to find out for sure, but I haven't heard back. But the Corporation for Supportive Housing has a virtual training center. And, anytime anyone comes to me looking for consultation, I will refer them to the Midwest Harm Reduction Institute. And if they can't fulfill that need, they're really good about referring people. Maybe it's because they don't have space, but maybe it's because they know there's someone in someone's backyard that they're not aware of who can do that work with them, who might understand them better. And so I think that, if folks are interested in that and they would contact me, I'm happy to bridge that conversation for folks. We're also exploring making the modules available through Chestnut, and we just haven't been able to do it yet, but I could light a fire if people are interested, and we can and what I would do is if people need consultation, reach out to the Midwest Harm Reduction Institute to see if that's something that they can help with or make a referral for. There are other organizations that are doing this work across the country. I believe Pathways to Housing does do technical assistance around housing first. So there's folks out there, and again, I'm happy to help. If people don't want to do the legwork themselves, I want to see people doing this the right way. I want to see harm reduction done the right way. I'm happy to help you get there. So.
And if I could just jump on, Dennis, thank you. That and reaching out to Dennis, it's also kind of like reaching out to me, because we partner a lot, and the Midwest Harm Reduction Institute can do a lot of things, and virtually too now. So yeah, I'm sure we can do some help.
Okay, great. Thank you so much. So, the question is, why isn't Housing First implemented more if we know it works? You talked about some of those barriers. I think funding, accessibility to housing, and a willingness to follow fidelity. Would you add much more to that, or that you, Dr. Watson, you talked about that in your closing slide, I think.
I think fidelity is a problem across things that we know are evidence-based. It's not just Housing First, and some of it goes to just not having the capacity or understanding. So either not having the resources to implement correctly, having barriers. We talk to a lot of places and they're like, well, we can't do this 100% the way you think it should be done. It's like, this isn't ideal. Like this, we want to help get you as close to here as possible. But we also want to help you understand, like, if you're, there's nothing wrong with other housing models. And some people want to be in housing that is, abstinence focused. That's what they're looking for. And so, sometimes it's walking through that discussion with, do you really need to be housing first? Do you really want to be housing first? But don't call yourself housing first if you're not going to try to get as close to it as you can. And you really have to do the harm reduction. And then to the big barrier issue, what we've seen is it is really, even if even if administration's bought in, staff can kind of interrupt that process. And I'm not advocating this as an approach for everybody, but I'm just giving it as an example, kind of an extreme example, but it worked for this agency. They knew that they were going to become housing first. They essentially made all their staff reapply for their jobs under this new model, and everyone was hired who reapplied, but 2 people decided not to reapply because they didn't want to work in that model. But it made it very clear to all those staff that this is what we're doing. This is our commitment now. And it made these 2 staff members understand that this was not something they were in agreement with, and this was not the place for them to continue. So, and it can be challenging too, because a lot of folks who work in this field have personal recovery experience, and sometimes they're not comfortable with, if they have an abstinence-based recovery, maybe they agree with harm reduction, and I know tons of people do, and others aren't comfortable, and they have to think about their own recovery and how that works for them and what their values are, and if they really want to be working in that model. So
that kind of leads to this next question. What about housing support when there are fewer options for housing, or community philosophy that tends to be more treatment first versus housing first? How do we provide emotional support when someone continues to be unsuccessful in finding appropriate housing? So it's kind of a couple things in there, but you know, abstinence versus harm reduction, housing stock, not as many resources. And I think this would also lend to kind of, we talking about Chicago and urban environments where there may be more housing opportunity, but rural environments where there's less opportunity, but still substance use and homelessness challenges, as well as criminal involvement. Any thoughts on that from any of you all?
I can jump in, and I'd love to hear from others too, but the first thing I want to say is I don't want to sugarcoat things. I believe we are in a housing crisis in America, and that we need to be asking questions like this, and we need to be speaking forthright and assertively that we need more affordable housing across the board, not only to prevent and end homelessness, but also lower paid workers are really struggling just to make ends meet, and housing is a big driver, is the big driver of that. So I want to put that out there. And that said, I think that in communities across the country, HUD funds a continuum of care in each community, whether that's Chicago, Peoria, Kansas City. It's a continuum of care. And the continuum of care should be, they're all a little bit different, but it should be very open to inclusion of any interested party, anyone who's interested in trying to end homelessness in that community, from certainly the tried and true homeless services providers and housing providers, but mental health providers, substance use treatment providers, people who work in the criminal legal space. So one thing that I always encourage people to do is to get to know your local continuum of care. You deserve to have a seat at that table. Most continuum of care would be like, here's the seat, please sit down. We've been wanting someone with your expertise. Others might be more insular, and you got to elbow your way in. But the continuum of care is sort of the town square of homeless policy and resources when it comes specifically to homelessness. So I'll stop there, but that every community, even very small, like very small cities have this.
And I think I was typing an answer to Faye's question when you asked your question, that hers was really, Dr. Taxman's question was really about what are maybe some housing policies that could help improve housing stability. So in there, I suggested, like Ed was just talking about, we really need to reduce barriers to employment. And I guess the added layer I would say on that is based on, there's a lot of barriers to employment based on felony, misdemeanor, or arrest histories. I also suggested working with local jurisdictions to make more affordable housing available, particularly for individuals with low incomes. Working with local housing authorities to reduce limitations or barriers to where people can live. Like particularly, you saw my stats on a lot of people are living with family members, but oftentimes local housing authorities will restrict the ability for people to live with family members because of them having an incarceration or arrest history. And then, like you alluded to too, is enacting policies that expand capacity for substance use, mental health, intellectual developmental disability, care and services. And the final thing I would add to that is really examining our zoning restrictions, because I'm sure both Dr. Watson and Mr. Stellen have run into places where, like, if they want to have, they want to do some housing related programs, that local zoning restrictions, or sometimes just even local residents, will kind of push those opportunities out of neighborhoods. So I guess that's what I would add on to your question.
Thank you. And that actually you partially answered the question, but your other suggestions about HUD or SAMHSA policy recommendations, and Dr. Pettis, you just talked about local housing authorities, where HUD pushed the authority down to the local housing authorities, and so jurisdiction to jurisdiction, there are different restrictions on who can live in those housing authorities, and perhaps it's something that HUD should take control over again. But from any of you all, any policy recommendations related to how to advance this work?
I mean, I would add just specifically to HUD and SAMHSA, if there could be maybe not necessarily, I mean, I don't really, I'm not going to comment on whether they should take it over or not, but there definitely, I think, needs to be more education of local authorities, local at the state level for who receives maybe some SAMHSA funds, and local at the housing level, because a lot of times my experience has been, I'd be interested in other people in the call, but with these federal pass-through money or block grant money, the local jurisdiction, no matter what the federal policy is, the local jurisdiction interprets it in the way that they either understand, but it's not always accurate, or the way that they would like to, and that isn't necessarily consistent with the federal authorities.
Great, great. Another question is, are there any housing services or solutions provided specific to homeless veterans, where they can also access substance use, mental health, and other services, especially given the over 420,000 homeless veterans on the streets any given day? So anything related to, does any of your research or anecdotal or information that you gleaned from your research that you maybe didn't drive down into your results, but veterans, where do they fit in this conversation?
I can jump in just a little bit. Again, this is just from my experience here in Chicago, and I realize the response to this question, unfortunately, is highly variable across the country, because if you've gone to one VA hospital system, you've gone to one VA hospital. So even though it's a unified system, each one, they seem to operate differently. And when I talk to my colleagues in healthcare for the homeless in other cities, it's not a universal experience. But in Chicago, our VA is remarkable. And they, generally speaking, when our outreach team engages a homeless vet, and right now in Chicago, that's not a terribly high number, they very quickly link them to the VA, because at least locally, there's a wide array of services and supports directed specifically to the vets. They are harm reduction oriented. This was not the case maybe 15 years ago, but they are now. They're strongly harm reduction oriented, and they have special housing just for the vets. And so for the most part, in our area, vets can move into housing much more quickly than non-vets can. And I mean, you know, there are homeless vets in Chicago, and at the same time, we say we're very close to functional zero in terms of veteran homelessness, because people can move so quickly into housing.
Okay, all right. Another question is, does your housing program serve individuals with a history of violence and or individuals who must register as sex offenders?
That I probably should jump in on that one, because I don't know, you guys probably don't have. So yes, and yes, qualified. So in terms of violent offenses, absolutely. In a harm reduction approach, it's not, honestly, if we have a good history on a person, that's golden, that's great. I mean, we have an honest, open, data-driven conversation with this person. Okay, so this happened. These were the consequences. Tell me about it. What were some of the antecedents? What can we do to, not have that happen again? How do I support you? What do you need to do? That kind of thing. Sex offenders. This is tricky, and this is an area I know in the city of Chicago, it's extremely, as close to the word impossible as I can imagine, to find a unit. So in our actual project-based, we are too close to schools. We can't. It's just illegal. And it would be, that person would be in violation. And that person would be violated. And so when it comes to the whole city of Chicago, when you look at parks and schools and childcare, and sometimes there will be a place, and then childcare will open up, and suddenly some place that was okay is no longer okay. There are very, very few options.
And Dr. Pettis, I'm wondering, in the data that you shared, there was a 10% group that were less stable. Does the sex offender status or violence status play any particular role in that group?
We didn't break those particular data down by those statuses, but other literature has certainly showed that having a sex offender registration status causes significant barriers to housing above and beyond that those with other incarceration, offense types for their incarceration status. And that's where you do have the most kind of housing restrictions imposed on people, or people just get pushed out of neighborhoods or of housing settings because their registry, their registry is public.
Okay. We're getting close to our time. Who funds case managers and staff at the housing programs, and our peer navigators and peer recovery specialists included in the staffing models?
I'm going to jump in, and I bet Ed can actually also answer a lot of this, but I've seen a lot of different ways in different states that folks are funding case managers. Oftentimes they're part of the program and they're housing case managers. They're funded through funds that support the program. I've seen other models where the housing agency is just offering housing and they will contract out to a case management company, which is often focused on mental health case management, which can and cannot be optimal because oftentimes those folks do not understand housing or how to intervene in housing issues that could be related to behavioral health issues. So I'll just say very quickly, it can be hard to get them sometimes to make the connection as to why it is important to talk about behaviors that impact the lease if you're just focused on in mental health training, to get them to make that connection and understand that, because if they see it as a housing issue, that's not billable for us. But it's like, no, it's related to a behavioral health issue that is billable to you. So, so yeah, I've seen multiple ways, multiple models in terms of how it's funded, and it can impact programming differently if you're trying to do any type of harm reduction or housing related intervention.
Okay. Ed, anything you'd add?
I'll tell you that I think that as hard as it is to fund housing, it's even harder to fund the services in the housing. I hate to say that because you would think it would be the opposite. Illinois is particularly bad. So we know that when we have individuals who are diagnosed with a mental illness, we can bill Medicaid to provide services and supports, just like Dennis said. And really anything, we can support any issue in that person's life as long as we tie it back to their recovery process from a mental health condition. I cannot say the same thing though with substance use disorders. We do not have that level of flexibility. And certainly for other folks who are reentry, maybe after some years, in custody, I mean, there's still kind of a learning process and getting none of that, very, very, very hard to fund. So I know with what time I have left in my career, that's my number one advocacy policy is like, here we have a golden solution. And, Dennis said, once we get staff on board and buying in, they have to cash a check every other Friday. They can't come to work for free. And we've got to be able to fund those services. We have a really good model when it comes to people with mental health condition. And it's just a patchwork quilt with every other pathway into housing.
So I'm gonna ask this last question.
Can I just jump in and
sure.
the final point from that question, yes, there are peers who work in these programs, but it's not a requirement of them. It just really depends on the program model.
Okay. And I'm sorry for stepping on that response. This was targeted to you, Ed, related to population with criminal legal involvement. The question says they're curious to hear how your program strategies is in navigating the HUD 90-day limitation on incarceration.
Yeah, so HUD says that, you know, people are in jail, usually this is jail at this point, for 90 days or more, then they lose their spot, essentially. So I have to say there have been some instances where somebody lost their place because they were there for more than 90 days. So we haven't like figured out a way to get rid of the law. But I will tell you this, that when for the most part, the judges in our system look very highly on people's affiliation with us in our programs. And when we're assertive, and again, this is that assertive word that Dennis hammered home, when we're assertive and we go to court on behalf of people, we work with their legal representative, we have been successful in getting people back while they're still awaiting their trial.
And I just add, come January 1,
yes,
in Illinois, we will no longer
Yes.
have a cash bail system. So
Right.
that'll play a huge role for us. But you know, hopefully we'll be able to still be able to, what you share will help people in other jurisdictions. So I want to thank all of the panelists again for your time and information that you shared. Braden, I think we have some slides we wanted to share as we exited. I want to thank Dr. Ducharme, Dr. Wiley in her absence, Dr. Faye Taxman joined us, and all of our colleagues with JCOIN, the Addiction Policy Forum. Thank you so much for participating. All of you who joined us from all over the country. Thanks again. We will have additional webinars coming soon. I think we shared the JCOIN website, so there's information from past webinars and other learning opportunities, as well as upcoming opportunities. And so thank you again for joining us. We look forward to for you participating with us again in the near future.